Okay, welcome members. It is exactly 8 p.m. and it is the time when this CM is meant to start, and it has started. I want to welcome you to this weekly webinar. My name is Tatuma Desmond Benjamin. I'll be behind to technically support the team as they lead us to the presentation. Today's presenter is Dr. Rebecca, and to be moderated by Dr. Tenywa Emmanuel. And the CME is very specific. It is brought to you in preparation for the World Asthma Day, which we shall be commemorating on 6th of this month. I will not go into much details. I will just tell you that it is a partnership. It's a collaboration between Busoga Health Forum, Makerere University Lung Institute, and Jinja Regional Referral Hospital, who have come together to bring to this session. And I want to invite Dr. Tenywa Emmanuel to take over. Over to Dr. Tenywa.
Thank you, Benjamin. Good evening, everyone. You are most welcome to today's webinar. Very interesting topic, and it is organized by Busoga Health Forum in collaboration with Makerere University Lung Institute and Jinja Regional Referral Hospital. The moderator for tonight is Emmanuel Tenywa. I'm a pediatrician at Jinja Regional Referral Hospital. And we are so glad to have our moderator, who is, our presenter, who is Dr. Rebecca Nantanda. She's a senior pediatrician. She's also a senior research scientist at Makerere University Lung Institute. She has a lot of experience in managing patients with lung pathology, most especially asthma. This webinar is basically a pre-World Asthma webinar in preparation for the Asthma Week, which is due for next week, and the World Asthma Day is on 6th of May. Tonight's topic is improving access to inhaled medicines for the management of asthma. And without wasting a lot of time, I want to set the stage by saying that asthma is a global health problem, and it affects approximately 300 million people worldwide. And just imagine 15 of these 300 million people, 15% of these are children. So you can see it's a big percentage. And as we all know, asthma is associated with an estimated 1,000 deaths per day. So just look at this, 1,000 patients die due to asthma per day. And actually, majority of these deaths occur in low middle income countries. And obviously, we know our Uganda is in the low and middle income countries. And as we all know, the prevalence is on the rise in the low and middle income countries. But also we should appreciate that the cost of care is so high for the health systems and in the individuals. But there's something that caught my attention in today's discussion about asthma. That's why everyone should be online, should log in. 9% of asthma is controlled. Just imagine 9% of the asthma is controlled. So it means there's a management gap among health workers. That's why this webinar is so timely. And just imagine 90.9% of these children are partially controlled or uncontrolled. 90%. And 80% of these children with asthma are undiagnosed. So it means there's a big knowledge gap in making a diagnosis among the health workers. So let me take this opportunity to invite our dear presenter, Dr. Rebecca Nantanda, our senior pediatrician and senior research scientist at Makerere University Lung Institute. Dr. Rebecca, you're most welcome.
Thank you so much, Dr. Tenywa. Good evening, everyone, or good morning, good afternoon, wherever you are. Could you kindly confirm if you can hear me?
Yes, you're loud and clear.
Okay, thank you so much. So, I I extend my thanks to the team that has organized this webinar, led by Busoga Health Forum, as well as Jinja Regional Referral Hospital. It's always a pleasure for us to be able to share some knowledge, and we hope that what we are sharing is going to help us to learn something that is going to really improve the care of our children with asthma. So for today, I'm going to be talking about improving access to inhaled medicines for treatment of asthma. And like Dr. Tenywa said, this is really in commemoration of the World Asthma Day 2025. So every year we commemorate the World Asthma Day on the first Tuesday of May. And each year we have a theme. So for this year, we are focusing on making inhaled treatments accessible for all. Doesn't matter where you are, who you are, whether you're young or old, as long as you have asthma, we should be able to have them access the medicines. And as we go through the presentations, I'll be highlighting the reasons why inhaled treatments for asthma is really very critical in improving asthma outcomes. So I'll briefly go through some definitions just to get us going, and then share some insights in the burden of asthma with a focus on Uganda. And then I'll talk about inhaled medicines for the management of asthma. We're going to discuss asthma medicines, access, and then some insights into what we think the future can look like to improve access to asthma medicines. So I'll start off with defining access to medicines. And WHO really defines access to medicines as ensuring that these medicines are available, they are within a functioning health system, they are present at all times, in adequate amounts, in appropriate dosage forms, with assured quality, and at a price that individuals and communities can afford. So it's such a long list, and each one of us, I assume we come from maybe a health facility, or we're working within the Ministry of Health Systems or district health system. I think this is something to think through, whether we really have all these characteristics of access when it comes to asthma medicines fulfilled within our health facilities. But when it comes specifically to asthma medicines, we know that besides those characteristics that I've described, the access is also influenced by certain factors. For example, the community being aware that their child or themselves might have asthma and therefore seek care. As health workers, to be able to diagnose and actually treat appropriately. But also for asthma, it's very important that patients or the caregivers have the knowledge and understanding of the disease and how it is treated, because this is a common bottleneck for accessing the care that children need. And the fact that the health system is designed to support long-term care. For example, we should be able to integrate asthma care into the health system, but also because it's a chronic disease, meaning that there is going to be follow-up, we should have systems that capture the data so that when I need to see what has been happening previously, I'm able to follow through. So I'm happy the Ministry of Health is picking up the issue of digitization of the health system or the health record system. And I think that will go a long way in really making us better clinicians, because we'll be able to have a look at the records and also maybe do operational research. But also very critical in terms of addressing the burden of asthma, the social support systems for the affected individuals, as well as the families. And this morning, we're in Jinja Regional Referral Hospital in Nalufenya, and we actually discussed that even as healthcare workers, we need some form of support, social support or psychosocial support when we are working with children who present to us with asthma. So now I'll shift to asthma. What is it that we are talking about today? So asthma is a heterogeneous disease, usually characterized by airway inflammation. So we find that the airways of people with asthma are inflamed, chronically inflamed. And because they are inflamed, this makes them hyperresponsive to external stimuli. That's why we say that there is hyperresponsiveness. And eventually that hyperresponsiveness leads to airflow limitation. So we usually have the common signs and symptoms of asthma being wheeze, shortness of breath, chest tightness, and cough. And these symptoms vary over time, meaning that they're not the same all the time and in intensity. Sometimes it may be mild, sometimes it is severe, sometimes it may be life-threatening. And it also presents with variable expiratory airflow limitation. This means that the narrowing of the airways as a result of the response to the triggers varies from time to time. It's not the same all the time. It's not fixed, so it varies over time. But also important to note that if we do not treat asthma appropriately, it means that there will be eventually airflow limitation, which is persistent, to an extent that even if you got the right medicines later on, you will not have the airways widening again and giving you the kind of breathing that you want. So Dr. Tenywa has already described, but just suffices to say that really asthma is a big problem globally. And like most problems, the low and middle income countries are affected. This is where we are. So I'll straight away go to what it looks like in Uganda. Apparently, we've been working in this asthma field for some time. It's now 15 years. And 15 years ago, the study that was done by Dr. Betimwene showed that 13.8% of children aged 8 to 14 years in urban primary schools actually had asthma symptoms. And later on, Dr. Niku also did a study. This was partly in Jinja and also in Kampala and some parts of rural Jinja region. And he did it in children 9 to 12 years and found out that 21% of them had asthma symptoms, those who were in urban settings, but also in the rural settings, up to 13%. This is very important because sometimes people think that asthma is the disease of the rich, it's the disease of the people in town, but you can see at least one person, one child out of every 10 had asthma symptoms. Now, I'll shift to the most recent study. This study was published last year. It was a study that we did in 6 countries in Africa: Ghana, Nigeria, Malawi, South Africa, Zimbabwe, and Uganda. And what we wanted to find out was the prevalence of asthma in children aged 12 to 14 years in urban secondary schools, how severe the symptoms were, and whether they were controlled. So I'll just share some few findings for us to understand the burden of asthma in this age group. So we had a total of 27,272 adolescents aged 12 to 14 years. And when we asked about the prevalence of wheezing in the past 12 months, that is the definition we use in population-based surveys to try and define asthma. So we had a total of 3,236, representing 11.9% of them, saying they had had wheeze in the previous 12 months. So we went ahead to look at these 3,236. We wanted to find out what was the severity of the symptoms that they had. And you note that up to 66.3% had severe symptoms. That is a huge population of adolescents having severe symptoms. Now, the most disturbing finding we had was that out of those who had severe symptoms, the 2,146, a whole 77.9% had never been told that they have asthma by a clinician, meaning probably they were not on treatment, yet they had severe symptoms. And I also want to share some of the hidden burden of asthma. We usually forget about this, but asthma is also associated with a lot of psychosocial challenges, both to the caregivers as well as the affected children. So in this particular study, we did some qualitative work, and these are some of the voices from the docents. So one of the docents said that when I'm in an attack, I can't do anything. I can't study. I can't go to class. I can't breathe properly. I can't focus. I can't understand. I can't be at school. So you can imagine she couldn't do anything. Everything was, I can't. You can only imagine the burden she was going through. And then another docent from Uganda said that I don't tell people that I'm asthmatic because they will start looking at me all different. So they are hiding the disease, yet they're having very severe symptoms. They are undiagnosed. They don't have the medicines. Again, this affects their life as a whole. It affects their education. It affects how they socialize with people. And then the last quote was from caregiver. Again, this was in Uganda. This was a caregiver of a child who was aged less than 5 years with asthma symptoms. So when we are asking about her experience, what she goes through when she's caring for her child, she said, I don't know where it will end. I don't know whether he'll just die or he'll get some assistance. I don't know how he'll get cured. I don't know where he can get better treatment. So you could see a caregiver who had a lot of I don't know, and I don't know, a kind of resignation, a kind of giving up. So those are hidden burdens, and we think that if we improve access to medications, some of these issues can actually be addressed. So I now shift to briefly talk about inhaled treatment for asthma. So when we say inhaled treatment, and I want to emphasize this, what we mean is that we want the medicine in the bronchi, not in the mouth. And that means that the technique of getting the medicine into the bronchi is very critical to ensuring that the children get better. So this is exactly what I mean, that this medicine should actually find itself in the bronchi, both the right and the left side, so that eventually we get the relief that we want from these medications. So it's very critical that as we think through access, we should do our part to make sure that we train our patients appropriately so that when they take the medicines, it actually gets into the bronchi where it is needed. It doesn't end up in the mouth. So what are the types of inhaled medicines that are commonly used? I think most of us know the nebulizer. Probably most hospitals and maybe some health centers have a nebulizer. So we can use nebulizing solutions, for example, salbutamol. We can use that to make sure that the medicine enters into the lungs. But there is also the pressurized metered dose inhalers, commonly known as PMDIs. And the common ones we know, there is salbutamol, there is budesonide, and others. But the thing is that the medicine comes out, you have to pressurize it. Actually, you have to apply pressure for the puffs to come out. And this also requires a particular technique of training the patient to be able to use it appropriately. Another type is where we have the dry powder inhalers, not commonly used in children, probably in adolescents. So these are really powdered inhalers. Again, the technique on making sure that the powder reaches the lungs must be told to the patient or trained so that the medicines or the powder gets deposited into the lungs. And then the other type, which not so commonly used, but it's also available, is where we have the rotor cup inhalers. This really are commonly dry powder capsules. And what we have here is that capsule that you see, it's inserted there, and then that's the mouthpiece. So the patient is trained on how to insert the capsule, close up some areas, and then press somewhere while putting the mouthpiece into the mouth, and then they're able to inhale the medicine. So these are some of the inhaled medicines that we're talking about. So I'm not talking about tablets. I'm not talking about injections. I'm talking about asthma medicines that need to be inhaled to have improvements in the asthma symptoms. So I'm going to briefly talk about the two categories of asthma medicines. So asthma medicines are either relievers or rescue, and these are commonly used in exacerbations or asthma attacks. Just like the name suggests, they're only used to relieve an obstruction which arises because there has been airway hyperresponsiveness, and now there is airflow limitation because the bronchi have become narrow. And they are commonly referred as short-acting beta agonists. That's the commonest that we have on the market, especially salbutamol, and sometimes we are able to have the levosalbutamol. So what is characteristic with this is that they're really short acting and they have a short onset of action very quickly. And then there is another type, which is short onset, long acting beta agonists. And what we know commonly is the formoterol. So this one, you will not find it as a single medication. It's usually in a combination inhaler combined with inhaled corticosteroids. But because it also has a short onset of action, but acts for a long period of time, there are certain severities of asthma where we actually use it as a maintenance medication, but we can also use it during exacerbation because the action onset is very quickly. So these are called relievers, and their only job is to relieve the obstruction. And then the other type, when it comes to inhalers, are the controllers. Sometimes we call them preventers. And these are mainly inhaled corticosteroids. So there are those where we find inhaled the corticosteroid only. So sometimes we refer to it as ICS plain. And then there are those where we have the combination, like the one which I've just described, where you have a combination of an inhaled corticosteroid with formoterol as the long-acting beta agonist. And other combinations have the inhaled corticosteroids and salmeterol as a long-acting beta agonist. So salmeterol does not have a short onset of action, so we cannot use it as a reliever, but it has a long-acting time up to 12 hours of use. So I'm going to briefly describe why we should give children short-acting beta agonists when they present to us with exacerbation. So the mechanism of action is that these medicines activate the beta-2 adrenergic receptors. These are found in the airway smooth muscle. So that's where exactly they act. So if you look at that picture, that tightening around the bronchi is the smooth muscle. So when it tightens, somebody cannot breathe. It contributes to the airway narrowing in addition to the inflammation. So when they activate these receptors, there are signals that are sent. A number of reactions happen, but generally there are signals that are sent. And what happens is that there is relaxation of the smooth muscles, those muscles that I've talked about. And eventually the airways are able to dilate. And because they have dilated, you have improved airflow in and out. And then the patient will tell you that now I feel relieved. Now, the good thing with these short-acting beta agonists, like I mentioned, their onset of action within 5 minutes, they've already started working. So the relief is starting to be realized. But also important to note that their duration of action is about 3 to 6 hours. And that's why it's very important that we give them in the right doses so that we don't get the children coming back again and again with an exacerbation just because we haven't treated it optimally. And then very briefly, for the controllers, like I mentioned, they're mainly inhaled corticosteroids, either as plain or in combination. And I want to emphasize that this is really the first-line therapy for asthma for all severities, whereas the practice may be different because of different challenges. But when it comes to recommendation, they're the first line of therapy that we should use. And their main role is to reduce the inflammation. And because the inflammation has been reduced, then there is reduced hyperresponsiveness. And because of that, then we have a reduction in the symptoms, but also the lung function improves. So this is their mechanism of action to make sure that the patient eventually has controlled symptoms. So I want to note that if we are able to really improve access to inhaled corticosteroids, the goals of asthma care can be achieved. And these goals, number one, to maintain good control of the symptoms and maintain normal activity levels for the patient. And very important, we want to minimize future risk of attacks, or what we call exacerbations, to prevent mortality, to prevent persistent airflow limitation, but also minimize medication side effects. So it's very important that we improve access to these medicines to make sure that our children are under control and they can live normal quality of life. So why is it that maybe we don't have good access to asthma treatments? What is some of the evidence that we have had that could highlight some of the reasons why there isn't good access to asthma medicines? So this was, again, the study that I talked about, which we did in 6 countries in Africa. And we went on to look at the children, the 27,322, where we said that 11.9% of them had wheezing, which was equivalent to 3,236. So when we looked at that section of children who had reported wheezing, only 644, representing approximately 20, had a formal clinical diagnosis of asthma. So the majority were not diagnosed. And there is no way you can access care unless you've received the correct diagnosis. So I really want to call upon us healthcare professionals to try as much as possible to always avail a diagnosis so that these children can access treatment and their symptoms are controlled. So one of the reasons we think is because asthma is really, really underdiagnosed in children. Then the second reason is probably because of our practices as healthcare workers. So this was a study, again, which was done in Uganda. And what we did was to observe healthcare workers during a consultation for children who had presented with cough or difficulty in breathing, because the entry point to assessing a child for possible asthma is really cough or difficulty in breathing, but also asking the relevant questions that would point you to the possibility of asthma. These were children who were less than 5 years. So the findings, really, these are really highlights. We found that less than 20% of the healthcare workers asked about recurrent cough, breathing difficulties, and wheezing. Yet, like I mentioned earlier in the definition of asthma, these are key symptoms that could point us to really arriving at a diagnosis of asthma. So this could be responsible for us underdiagnosing asthma. And then the second part where we're looking at the signs, again, only 10% checked the respiratory rate, checked for chest indrawing, and listened for wheezing. Again, these are missed opportunities to try and diagnose asthma when children come with acute exacerbations. And this is also very critical in Uganda because in most cases, the first time when you're able to think about asthma is when they come with an attack. And so we should make an effort to really do comprehensive assessment to try and diagnose asthma so that we can reduce the issue of underdiagnosis of asthma in our children. And then I want to talk about the clinical guidelines. So in Uganda, we mainly, especially in primary care settings, we use integrated management of childhood illnesses. I think the last edition was 2014, but this year they brought out a guideline which going up to, I think, 10 years. There's a bit of improvement there. But I wanted to mention that for this particular edition, which is 2014, is what we've been using for a long time. And then in some cases, we have another guideline for hospital, the pocketbook of hospital care for children. So within these guidelines, and I'm going to focus mainly on IMCI. So in IMCI, there is what we call the cough symptom. And like I mentioned, usually the cough or difficulty in breathing, that helps us to think about the possibility of asthma in these children. So in these IMCI guidelines, the chart booklet, first, they tell you to look and listen for wheezing. So when a child comes to you and they have cough or difficulty in breathing, besides counting the breaths per minute, looking for chest indrawing and listening for the stridor, we are also supposed to look out for wheezing. And they say if wheezing with either fast breathing or chest indrawing, then we should give a trial of a rapid acting inhaled bronchodilator for up to 3 times 15 to 20 minutes apart. And then we're supposed to reassess and see if the child has improved. Now, the reason why I highlight this, the emphasis is on wheezing, and yet, like the symptoms I mentioned, it could be cough, breathing difficulties, and wheezing, and these are recurrent symptoms. And yet we know from research that it's just about 35% of the children who actually present with wheezing as a symptom. So again, when we use wheezing alone as an entry point for diagnosis of asthma, we miss out on many children who would otherwise be diagnosed if we're able to assess more comprehensively. The good news, I think WHO has realized this, and there are revisions that are coming up that are going to have more focus on asthma. Again, when it comes to treatment, the focus is on wheezing. And they say if wheezing or disappeared after rapidly acting bronchodilator, give an inhaled bronchodilator for 5 days. So this could be a child who is coming for the first episode of an attack, and all you're doing is giving a bronchodilator and then sending them home. If you're using wheezing alone without using other symptoms, that's a challenge. But also, we're trying to emphasize follow-up of these children to be able to tease out the issue of the recurrent symptoms. So just sending them home with a bronchodilator for 5 days is not sufficient. That's how we end up losing them to follow up and being able to diagnose the asthma early. In some cases, they will say if coughing for more than 14 days or recurrent wheeze, refer for possible TB or asthma assessment. This is a good thing, but again, our system may not, our referral system is not very, very robust. So again, we find many of them may not go for referral of assessment by a specialist, and therefore they end up being undiagnosed for quite a long time. And the issue is that whereas when the symptoms are continuing, they're using other medications like cough syrups, they're using a lot of antibiotics, both oral and intravenous. We are using a lot of steroids. And we are starting to see a lot of children actually having side effects of overuse of steroids. And yet the appropriate medicines could be available to them to control their symptoms. Now, the question is, I've talked about the inhaled medicines, I've talked about the short-acting beta agonists, and then the controllers or the preventers that are mainly inhaled corticosteroids. Are they actually accessible? Are they affordable? Are they available in Uganda? So this study was done by Chibirige et al. And it was published in 2017. They looked at access to affordable medicines and diagnostics for asthma and COPD in sub-Saharan Africa. But in this case, we specifically focused on Uganda. So this is what happened. So the survey was done in 22 public hospitals, 23 private hospitals, and 85 private pharmacies all over Uganda. Now, when they looked at the availability of short-acting beta agonists, 75% of them had, which was a good thing, because then we hope that people could access them to manage asthma exacerbations. And then when you look at the Montelukast, which is a leukotriene receptor antagonist, this one is also used as a controller, but it's not inhaled. That's why I did not talk about it. At least in 60.8% of the facilities surveyed, it was available. And then they looked at the inhaled corticosteroids and long-acting beta agonists, the combination that I talked about. It was available in less than half, just 46.9%. And then the plain inhaled corticosteroids, lower, 45.4%. Now, they also looked at the diagnostic tests for asthma, that's mainly spirometry. It was available in only 24.4% of the facilities, and peak expiratory flow meter in 6.7%. So overall, you can note that the medicines or the inhaled medicines, which we use to control asthma symptoms, were available in less than 50% of the facilities that were availed. But also note that when it came to public hospitals, where majority of our patients actually go for care, there was extremely low availability. It was mainly the private hospitals and private pharmacies, meaning that if patients needed to access them, then they needed to have money. So they went ahead to look at whether those medicines were affordable. And the way they looked at it, they asked if you are, how many days of your wages would you have to part with just to buy one canister? So for salbutamol, which is a short-acting beta agonist, one had to look at least 2.2 days of their monthly wage just to buy that one canister. When it came to the inhaled corticosteroids and LABA combination, more than half of your wage had to be spent on that one canister. And then just to get a test for spirometry, almost the whole month's salary needed to go just to do that particular test. So with this, you can see that the affordability is really a big challenge. And probably that's why most of our patients are not able to access these medicines. So we've been thinking through as researchers, what are the potential interventions? What can we do to try and improve the situation? So what I'm going to share are some of the studies that are ongoing and they are taking place within the Busoga region. And we hope that if the findings are good, probably we can start thinking about changing the problem of underdiagnosis, of healthcare workers' skills and knowledge, and eventually be able to even improve the access to the medications. So the first study that I'm going to describe, we call it All-Right study. And in brief, it is acute lower respiratory illness treatment and evaluation. It is conducted in children who are less than 5 years in some primary healthcare facilities in Jinja district and Jinja city. So what we've done is to improve the IMCI guidelines, and Mmed included a more comprehensive assessment of possible asthma in children. And we put it on a digital platform, which we call Noviguide. So using that tool, you're able to assess if there is an emergency. You're able to assess a child who doesn't come in as an emergency. You're able to check on the progress. Now, the beauty with this is that because all that information is provided on this digital platform, you're able to navigate the application, and it helps you to support you to find out whether this child has asthma. But doesn't end there. It also directs you, guides you on how to give the bronchodilator, and then check the response, and then it reclassifies you and guides you on what next to do if the child has possible asthma. And if there is no asthma or other illnesses, then it also gives you some guidance. So we can use it for other diagnoses, which are for the respiratory system, but also other problems like diarrhea and fever in children. So we think that if this study concludes that this is really feasible, it's acceptable, but also is effective in helping us to diagnose children with asthma and other illnesses very easily, maybe it will improve on the adherence to the guidelines, but also it will improve our capacity to be able to diagnose the children with asthma and manage them appropriately. This study is still ongoing. Probably next year we shall be able to get some results, but we are hopeful that maybe we'll get some results to see how we can improve our competencies. Then the other study that I want to describe is a study where we are looking at different interventions to try and improve access to asthma care for children and adolescents in Uganda. We refer to it as the ACA study, and it has 4 sub-studies in one. So just to describe, the first sub-study is really looking at routine screening for asthma symptoms. Let me try and see if I can get a pointer. So the first study, the first intervention we are looking at is routine screening for asthma symptoms. So what we are trying to do is, if we asked a few questions to every child who comes to health facilities with complaints or call for difficulty in breathing, can it help us to actually find out if they could be having asthma? And then we conduct a more comprehensive assessment. And these are usual questions. Do you have a cough? How often do you have it in a year? Do you sometimes have breathing difficulties? Have you had wheezing in the last 12 months or the last month? Because those are the questions that we've been missing out all the time, we think that if we make it as part of routine practice, it can increase our suspicion to be able to diagnose children with asthma. So this is ongoing. It is a cluster randomized trial, and we hope we shall be able to generate evidence that could potentially help us to implement this routine screening or these questions as part of the routine assessment. Then the next study, again, an intervention, is what we call needs-directed healthcare work training and mentorship. So this was in response to the study I showed earlier, where we noted that most of us healthcare workers do not ask the right questions, do not examine properly. And when we did the qualitative interviews, the issue was that there was a knowledge gap, there was a skills gap. So we designed an intervention where we're going to train and mentor healthcare workers in diagnosis and management of asthma But the issue is that it will be needs directed, meaning that we respond to the gaps that will be highlighted by the people who are managing the patients, so that at the end of the day, we are able to strengthen their capacity. And we hope that if we do that, probably it could strengthen the capacity and there will reduce the issue of underdiagnosis and poor management of asthma, and eventually have controlled asthma in our children. And then the third sub-study is also an intervention, a cluster randomized trial, where we are looking at community health workers, mainly VHTs, and we want to see if they can support giving asthma education to our patients. We recognize that sometimes the health workers are so busy, they may not give sufficient health education. And yet, if you look at the long-term management of asthma, one of the pillars is asthma education. We tell patients about asthma, the disease, the symptoms, how to avoid triggers, how to use the inhalers, the inhaler technique, when to come back. There is a lot of information that needs to be told to these patients. So we are trying to see, could community health workers support the health workers in the health facilities to give this asthma education, whether in the health center, whether in the communities, so that they can also contribute to really ensuring that these people have controlled symptoms. And then lastly, this is not necessarily an intervention, but in a way it's an intervention. So we are looking at a group of patients, children and adolescents, as well as their caregivers who have asthma. And we are going to find out if they have any psychosocial challenges because of the disease. And our hypothesis is that if we train healthcare workers and they're able to have the capacity to diagnose and treat asthma appropriately, probably we can reduce some of the stories that I talked about, the psychosocial challenges, such that we reduce the psychosocial burden by some of the interventions which we think we can afford within our health facilities, like training and mentoring healthcare workers, borrowing on other programs that actually also routinely train and mentor healthcare workers. So this study is still ongoing, and hopefully if we are able to get some positive results, whether in the capacity of the healthcare workers or in routine screening or asthma education, we think that these can help us to diagnose the children early, give them proper medication, and in a way be able to highlight the burden of asthma in our facilities. And probably this could stimulate us to plan better to make sure that the medicine that I'm talking about can actually be availed. So in summary, I've talked about the high burden of asthma in children and adolescents in Uganda, with a focus on the prevalence, the problem of underdiagnosis, the uncontrolled symptoms, as well as the psychosocial challenges. I briefly talked about the role of inhaled medicines in asthma care, and I think I want to emphasize that this is really the first-line therapy. It's not the oral salbutamol, it's not the oral steroids. We know some people who have been on steroids almost every day for so many years. As a controller, the preference is really inhaled medicines. Even for asthma exacerbations, it's not the hydrocortisone IV. Let's try and get oral, rather inhaled medicines for our children. And then we've tried to provide some evidence what we think are the potential reasons for poor access to inhaled treatments in Uganda. But I must emphasize that we need to search more. Why is it that we don't have medicines? But like I said, we have a role to play as health workers. We must diagnose the children. We must make sure that we put them on the right medicines, and in a way be able to highlight the burden, and then we can look for the resources we need to bring in these medicines. And lastly, I've just shared briefly about the potential interventions for improvement, and I really want us to think together. This is really just a small slice of the problem that we are trying to address. There are many problems we need to think together to see how best we can improve access to inhaled medicines for our patients. So I want to acknowledge the teams. All these people are playing a part. Very grateful to Busoga Health Forum. They're supporting us in our research activities in kind, but also technically. The Jinja District Health Office, they're always really very supportive. City Health Office, Jinja Regional Referral Hospital, we are working with them to support the health workers in the lower level facilities build their capacity. So we are looking at building at a resource within the region that can improve asthma care. Again, the research team, those who are in the health centers in Jinja, and as well as the Makerere University Lung Institute. And this work, which I've described, is being done in collaboration with two institutions. One is Queen Mary University of London, UK, for the ACA study. And then the ORITE study, it's being done in collaboration with the University of Washington. And the funding is coming from UK for the ACA study, UKRI MRC, and then the National Institutes for Health in USA. And before I sign out, I want to say that Makerere University Lung Institute, we are celebrating 10 years. We started in 2015. So on November 27th and 28th, we shall have the climax of the event where we shall be celebrating a decade of advancing lung health research, lung health for all through research, training, and patient care. And you're all welcome to join us in these celebrations. But before then, we are going to be having a series of webinars and other community activities. Again, you're all welcome to join us to see how we can address the problem of lung health in Uganda. Thank you so much for listening to me. I'm happy to take questions or comments, but for now, I'll pass on back to the moderator. Thank you.
Wow. Thank you so much, Dr. Rebecca, for the very informative, educative presentation. And I think all of us have learned something today. Each day we keep on learning new information. So the way to go from what Dr. Rebecca is saying is inhaled treatment, either ICS, and as you've heard, we have both the reliever medication and the controller medication. So this is now with questions, comments. So you just send in your chat and I can read it. Already I can read some chats here. People are just saying thank you for sharing the information. And someone was asking whether you can provide a soft. Someone is asking that can we get the ORITE tool, soft copy? Maybe Dr. Rebecca can answer.
So let me go through these comments as they came. I hope I don't miss any of them. So somebody said most of these inhalers, that is the short-acting beta agonists and LABA, are few or not available in public settings. They buy them from pharmacies. Yeah, I think it was a comment. And they say, Dr. Rebecca, say something on GINA guideline with emphasis on children. So first of all, I think I want to say that something to emphasize that the short-acting beta agonists can be like in a single inhaler. We don't have LABA as a single inhaler. The long-acting beta agonists are always in combination with inhaled corticosteroids. Now, for children, we do not use combination of ICS LABA in children less than 6 years. There are many times where we have received children or who have been prescribed the combination inhalers. Please, when it comes to children less than 6 years, regardless of the level of severity, the choice of the inhaled corticosteroid is the plain one. There is beclomethasone, there is fluticasone, there is budesonide, whatever you're able to get on the market. And you can consult GINA for the dose. For children 6 years and adolescents, you can use the combination inhalers. Again, if you go through the GINA guidelines, they will guide on which inhaler combination to use, at what step you're able to use it, what are the alternatives, how to step down, how to step up. But yes, I agree, it's still a challenge. And that's why I said that besides the definition by WHO, we have a challenge of getting the right dose, especially for the children. We don't have the ones that are 50 micrograms. For the little ones, would want to use, for example, budesonide or beclomethasone of 50 micrograms. They're not available. So you have a trade-off if you have 100 micrograms and you give it once a day, and yet you'd have preferred to give 50 twice a day. So we still have some challenges, but I believe little by little we can be able to address them. I don't know exactly what you wanted for the Jinja guideline, what to emphasize, but maybe, again, something about children less than 5 years. The diagnosis is a little challenging. It's not straightforward, but do the listening, do the talking, communicate. You're usually able to tease out some of these things. The all right diagnostic tool. So this is still under study. It's not yet, we don't know whether it's feasible, acceptable, whether it gives the clinical effectiveness we are looking for. We don't know whether it's cost effective. But once we are able to know that, well, it gives us what we want, people are happy to use it, it improves the outcomes, then we shall be working with the Ministry of Health to see how it can be scaled up in other facilities. So for now, it's still under research, and it's only being researched or used in those areas where the research is taking place. The CPD link, I think that one I'll leave to BHF.
Then Ronald at WebMB is asking, Dr. Rebecca, comment on the inhalers and environmental pollution / climate sustainability.
Okay, very good discussion, because I also have interest in air pollution and climate change. So there is a discussion that is going on, the inhalers and not, like, I would say, environmentally friendly. First of all, the canisters, the disposal, and all that thing. But when we are talking about inhalers, whether to talk about them as a problem because of climate change vis-a-vis the burden of asthma, we've agreed as researchers from low and middle income countries that when it comes to health, probably climate change is not high their priority when you consider really just getting our people accessing those medicines. Look at the statistics that I presented. If you have 66% of the children having severe symptoms, are you going to say, please do not bring inhalers and we let our children suffer? If we have up to 80% of our children not diagnosed and they have severe symptoms, so it's kind of a give and take. Whereas we recognize that there are challenges when it comes to climate change, but the priority for Africa right now, for Ugandans right now, is to get those medicines to our children and they get controlled. So as the high-income countries now start manufacturing more climate-friendly medicines, then we shall be able to actually also probably jump on board. But for now, what is available and what we are crying out for is to get these medicines accessed to our children so that they can live healthy and productive lives. I think that's what I can comment. So how do you handle the issue of airway remodeling in children on Saba? Oh, sorry. Maybe let me go through this comment.
Yeah.
Yeah, sorry.
Then Veronica Muchal was just thanking you. Thank you, doctor, for the presentation. Yeah.
The presentation, I'll pass it on to I think, Benjamin. But then there is this issue of how do you handle the issue of airway remodeling in children on Saba and black box warning with Montelukast. Okay, so let me start with short-acting beta agonists. Number one, like I mentioned, it's only a rescue medicine. It only gives relief. So if you go back to what I defined as asthma, it has chronic inflammation, which leads to hyper-responsiveness and then airflow limitation. Now, when you give Saba alone, you're actually promoting or putting the child at risk of airway remodeling. Airway remodeling means that, in simple terms, the muscles become like hardened. You're no longer able to reverse the obstruction because they have become stiff, they have remodeled, in really simple terms. So you get fixed airway obstruction. So what we recommend, if you go through the Jinja guidelines, we say now that every time a child, depending on what step they are, some of them, every time they receive a Saba, they must receive an inhaled corticosteroid. But there are some children where straight away, because of the severity of the symptoms, you put them on inhaled corticosteroid. So the cornerstone for management of asthma, regardless of the severity, is that there must be an inhaled corticosteroid to take care of the inflammation. And for some children, you actually give it as a daily medication. And that's why we say asthma is a chronic disease, but the symptoms may not be present all the time. They may be variable, but the inflammation is ongoing. And if you don't address it and only give the SABAs, then you are promoting airway remodeling. So how do we handle that issue? Please, let's give the inhaled corticosteroids to control the symptoms, to prevent the attacks. And when we do that, we will not actually need the SABAs. And maybe just to add that there is a lot of research where we know that use of SABA alone is associated with a lot of deaths. So again, if we use SABA only, then we're also promoting or increasing the risk of death in the children. So in government health facilities like Health Center 3s, we have a tin of prednisolone supplied every once a quarter. I'm really hoping that the healthcare planners, the budget holders are here. We now know how best we should be treating asthma. I think we can, and we can improve our skills and knowledge, but also get the supplies to start giving the inhaled medicines. Prednisolone, we use it only in attacks and for a short period of time. I won't go in this right now. Please don't give prednisolone as a controller because the side effects are really so bad. We've seen children suffering with kidney disease because of the use of the prednisolone. Let me see. What could be the best intervention to support children with acute asthmatic symptoms but has clinical resistance to steroids as a result of abuse, knowledge gaps from health workers? So, like I mentioned, when you diagnose acute asthma or asthma exacerbation, use the short-acting beta agonists because they are the relievers. They will open up the airways and the child will be able to get relief. But we also need to add the steroids. I think probably that will be another discussion for another day to stop the inflammation from ongoing. Now, the challenge usually comes in if we don't use the right dose. The common problem is that people use a very tiny dose of the steroid and then the children don't get out of the exacerbation. So let's make sure we have the right dose of the short-acting beta agonist and we have the right dose of the oral steroid to take care of the exacerbations. Maybe at some other point, I'll be able to discuss how to manage asthma exacerbations. Give your opinion on the... Yeah, sorry?
Yeah, it's okay. You can continue, Dr.
Okay. Yeah, give your opinion on use of spirometry in asthma diagnosis and use of ORITE. So ORITE, I mentioned, it's a tool we are trying out to diagnose asthma and other illnesses in young children. Probably, I think I won't go into that again. So spirometry. Now, spirometry is a test which helps us to, in simple terms, find out if the airways are narrow as a result of asthma and even other diseases. Now, like I mentioned, the obstruction, the symptoms are variable. The airflow limitation is also variable. So sometimes you do spirometry and you find that the volumes that the patient is able to exhale are within the normal range. That does not mean that that patient does not asthma. You always have to get back to the definition. Sometimes you find that the volumes are low. You give a bronchodilator and then the volumes increase, meaning that there is reversibility because you've given a bronchodilator, which usually confirms asthma. But I must emphasize that a normal spirometry result does not rule out the diagnosis of asthma. Always take comprehensive history, carry along your history as you interpret the spirometry results. I think that's what I can comment.
Maybe we have more more chats. Someone is asking, Dr. Rebecca, is there any environmental factors that cause asthma? And is there any early interventions that can be done in children? From Christine.
Okay, Christine, yes. So environmental factors. So the manifestation of asthma symptoms, what we know commonly is that somebody has the genes and they interact with the environment to lead to the inflammation and the eventual hyperresponsiveness. And some of these issues include like allergens, where you have the animal dander, the cockroaches, the pollen and other things. I think that is the typical kind of pathophysiology that we know of, but I must say that there are some cases where it's not that typical type of really response. So environmental factors, yes, but other things which are usually ignored, yet they are very important in taking the history, is things around being overexcited or angry, triggering the symptoms, exposure to cold, exercise. Those are not necessarily allergens, but we know that they contribute to the asthma symptoms. So yes, the environmental factors are there. And in terms of prevention, I entirely agree. Let's prevent air pollution. Let's prevent those environmental factors which would otherwise interact with the genes, and then we have the manifestation of the symptoms. But also it's very important that if somebody's on treatment, we try as much as possible to avoid the triggers so that we can have the symptoms controlled. Otherwise, if you don't control those triggers, even when you give the right medication, you may continue having the symptoms.
Then she is asking, what are the contraindications for nebulization? Yeah.
So I think you're talking about contraindications to using salbutamol for nebulization. So we know that some children react or get severe side effects with salbutamol, especially the tachycardia. It can go out of hand. But also some of them get, I don't know, simply call it tremors or shaking of the hands. Some of them become hyperactive because of the use of the salbutamol. That's why we usually say that please monitor the patient, reassess the patient, reassessment for the symptom improvement, but also do the heart rate, do the oxygen to make sure that the child is not getting the salbutamol side effects. So for such children, once we realize that they overreact or they get severe side effects to the salbutamol, then would not give them. Would probably give an alternative which has less side effects, that's the levosalbutamol. Or if they're older and they're able to take the combination inhaler, that's when we use the ICS formoterol, because we know that we can use formoterol as a reliever because it has a short onset of action. But having said that, to prevent the use of short-acting beta agonists, give the patient inhaled corticosteroids because those control the symptoms, they control the inflammation, and then the child will not have attacks that require the use of short-acting beta agonists. Any role of bronchodilators, as this seems to be very common in over-the-counter medications. Like I mentioned, the preferred route is really the inhaled corticosteroids. It's a tiny dose. It's in micrograms. Recently, we did some mathematics with one of the healthcare providers. I asked them, how much salbutamol do you give? They said 4 milligrams TDS or 2 milligrams TDS. And then I said 1/2 of salbutamol inhaler has 100 micrograms. And if I prescribe 4 puffs, I'm prescribing about 400 micrograms. But we know that 1 milligram, I think, is equivalent to 1,000 micrograms. So if you give 4 milligrams, you're essentially giving 4,000, micrograms. And yet if I give an inhaler, I'm down to 400. So the preferred is the inhaled medication. Onset of action is very quick. It has very minimal side effects. The relief comes on very quickly. So we should be phasing out oral bronchodilators. I don't know.
Someone is asking about natural remedies for asthma.
Natural remedies, I don't know any. Probably are talking about the herbs for asthma, but I know that research has shown that nutrition, but not as a treatment, but if the airway is inflamed and all this inflammation is going on and you give nutritional supplements, in some cases it can support, but does not replace the inhaled corticosteroid. But in terms of herbs, I probably haven't come across herbs. I know there is a lot of research going on in herbs. I would need to read around that. Somebody's asking about malnutrition. Those with malnutrition, the same treatment as those without malnutrition. Yes, the problem is in the airways. They are hyperinflamed, they are obstructed. Please give the medication. We don't have malnutrition being a contraindication to using asthma medication. Now, I don't know at what age can I diagnose asthma. Asthma diagnosis is not age dependent. Please ask for the symptoms. You might get a child who is 8 months and the mother is clearly telling you that every month I go to hospital, there is wheezing, there is breathing difficulties, there is shortness of breath, or there is cough, triggered by cold, triggered by an upper respiratory tract infection, usually viral, triggered by a lot of crying. So it's not age dependent. Please do the history taking. The recurrence of the symptoms will help you make a diagnosis. I think that is all.
I think maybe the last one, Agut is asking, is it possible to diagnose asthma at old age? Because I had such a patient and I wasn't sure because she was 58 years.
Yes, my answer is absolutely yes. I don't know whether my colleagues, the physicians, are here. Asthma can occur at any time. The symptoms can start at any time. And remember, I said that it's genes usually interacting with the environment, but there are some other issues like occupational asthma. If you've been exposed to air pollutants, maybe you moved from the village where the air was a little clean and then you came to the town, you're working in a cement industry. So asthma symptoms can start at any age, even in 80-year-olds. But again, when our colleagues, the physician, are usually able to do the history, when they do the spirometry, they are able to find out whether it is asthma or it is COPD. So in such cases, really spirometry becomes very, very important.
Thank you so much, Dr. Rebecca, for ably answering all these questions and the comments. And I want to hand over the mic back to Benjamin.
Oh, thank you so much, Dr. Tenywa, for moderating the session, and Dr. Rebecca, who is so passionate about babies and children. Thank you so much for a wonderful presentation. I want to invite Dr. Mkembo to give a vote of thanks to the team here, and then we'll invite the ED to close the session. Over to Dr. Mkembo.
Thank you very much, Desmond. And once again, receive my appreciation, all those who always make an effort to join us every Friday. We don't take your time and finances or data for granted. As a Busoga Health Forum team, we take pride in you choosing to join us every Friday. We are so grateful. And to our presenter tonight, Dr. Rebecca, you have been one of our fundamental presenters in Busoga Health Forum. You have severally presented to our audience. You are our member and as well a mentor to many of us as your junior health workers. We are very grateful that you always make an effort to give us that detailed presentation. I'm also very grateful that you are so passionate on respiratory issues, especially asthma. And those who have been attending your presentations, especially those who are handling children and people with respiratory issues, I guess by now they have had a change in the way they approach management of asthma. I'm very grateful, Doctor, and send our regards to Makerere Lung Institute for always allowing you to spare time to prepare these slides and as well sparing time to join the Busoga Health Forum. We are very, very grateful. And to our own senior, Dr. Tenywa, we are not only grateful for the mentorship, but also for the service you offer us, both at UHI and Nalfenya. Your hand has reached several people and testimonies keep flowing. We are thankful that despite being high up there, you always lower yourself and do moderation of such sections. Session is when we host senior colleagues to make presentations. Thank you very much, Dr. Tenywa, and thank you very much, Dr. Rebecca, for putting up this very wonderful presentation. I want also to thank our team at the Secretariat Desmond and the team that always make sure that the sessions are organized timely and we have timely links shared to those who attend. And like I noted in the beginning, to all those that make an effort to attend, we don't take you for granted and we are forever grateful. We would like to use this effort before I invite the ED. Allow me request and also invite you to join us as part of Busoga Health Forum active members. Please join us. Usually for active membership, we ask you to make a subscription of 100,000 per year. That subscription supports us to keep subscribing even to Zoom links like these ones. Expanding them requires money, but also facilitating the team at the Secretariat to keep other activities running. So we request you to join us as a full-time active member than a QAS member or a dormant member who joins once in a while. So that activation allows you to participate fully in all activities of the forum. And you also have a right to be voted, to vote whenever we have change of leadership. And there are several other benefits which come along with being a member. Every year you have your membership certificate awarded to you. And if we have those activities requiring specifically members or programs or benefits or scholarships or projects, we will select you as a member to be part of it. But presenting to Busoga Health Forum audience is entirely free. You do not have to be an active member. You do not have to pay money. It is free and welcome all cadres, nurses, clinic officers, doctors, professors, whichever level you are. Just put together your presentation, inbox me or Desmond or our ED, anyone, or even Professor Peter. Let us know when you are flexible, either as an individual, as a hospital, as an organization, as an NGO, whatever you are. We shall be welcome and very happy to receive you and give you audience to present Busoga Health Forum. Once again, Dr. Tenywa and Dr. Nantanda receive our sincere appreciations for the presentation you have given us tonight. Allow me to register apologies from our CEO. From our Board of Governors, Professor Peter. He reported that he has network issues. I don't know if I managed to join again, but he was really serious to join us in this presentation. Allow me to invite Mr. Moses, our CEO at the Secretariat, to give us closing remarks. Thank you very much. Moses, are you on?
Yes, thank you so much, Dr. Robert, for supporting us in this important activity. And to our colleagues and senior friends here, Dr. Rebecca, thank you so much. Busoga and the entire world is proud of your work here. Thank you for saving a number of lives through your projects, and then also sparing time, like Dr. Mkemba said. And then the team that you're working with to do a lot of work here in Busoga, the Dr. Tenywas and his department at the Jinja Regional Referral, and all the members who have attended this. It has been so amazing. We are so grateful. Thank you, and we keep inviting you to do more. I know you have a number of activities this week and next week as we celebrate important days in asthma activities. We thank you so much. And we want to take this opportunity to extend our appreciation, sending to you this important certificate that has been signed by our board chair, Professor Peter, that you take it and use it to continue educating the world. But we give you this token as a sign of appreciation that Busoga Health Forum appreciates all that you do, and God bless you so much. And to Dr. Emmanuel Tenywa, our neighbor, our friend who resides in the region, we thank you so much, Doctor. You have touched so many lives in Busoga, but we thank you particularly for today for saving some time to come and talk to the communities in Uganda. We don't take your time for granted. We thank you so much. And everyone who has attended, thank you so much. We have a number of activities running through the leadership of Dr. Rebecca as we celebrate the World Asthma Day. We invite you to a number of these activities that we shall be sharing on these different platforms. Thank you, everyone. God bless you so much. Have a good night. God bless you.
Thank you. Thank you so much for the certificate, and thank you to everyone. We really appreciate Busoga Health Forum and everyone for the friendship and for the support. And on behalf of MLI, I really want to extend our thanks to everyone and have a good night.
Thank you for the certificate. Good night.
Yeah, thank you, members.
Thank you so much.
Next week, we shall have two same sessions. On Thursday, we shall be having a team that will be presenting. I think, Dr. Tenywa, do you want to make that remark to tell people about the CME on Thursday before you leave?
Yes, I can. Thank you, Benjamin. So next week, we are having heart surgeries. There are children we are operating at Jinja Regional Referral Hospital. It's a collaboration between Uganda Heart Institute and the Jinja Regional Referral Hospital and Busoga Health Forum. So we are operating children we are doing closed heart surgeries, and so far we have admitted them, and we shall have a CME on Thursday, 8th of May. It will be a Zoom, and we shall be talking about congenital heart disease in children and also rheumatic heart disease, which is now a monster. And the presenters will be Dr. Ndagire Emma. She's a pediatric cardiologist at Uganda Heart Institute. And Dr. Ali Kutwalib is a consultant pediatric cardiologist at Uganda Heart Institute, and I'll be moderating. Thank you so much, Benjamin.
Thank you very much. Indeed, it was a very informative and educative presentation. Thank you.